case. This is a patient who was a performer, a vocal performer. He basically he was currently working as a singer on cruise ships. This is before COVID, obviously, and he was very reluctant to have traditional sinus surgery. This is his endoscopy. He had failed medical treatment with antibiotics, courses of both topical and oral steroids. He's got a lot of mucosal edema, septal deviation, middle turbinate is swollen. You can see a little bit of thicker mucus. That's the right side. This is the left side. Visualization on the left side is a little bit easier. You know, he was very reluctant to have a procedure done in the operating room because he was terrified of intubation affecting his vocal cords. And he heard that we did office procedures, and so he wanted us to do an office procedure for him. Okay, so this is his CT scan. So you can see his septal deviation. He sort of has this patchy inflammatory disease. It's more frontal than anywhere else. And so our main concern was getting the frontal sinus and secondarily the maxillary. But he was not going to be easy because of the degree of edema in his nasal cavity on the right side and that septal deviation. And then a little bit of posterior ethmoid disease as well. Okay, so this is a video. We anesthetized in the same way. He decongested pretty well, so we've got a decent view. And here we're passing our Acclarent balloon introduction catheter. And we're trying to sort of hook the back end of the uncinate process and start to pass the wire. And I remember when I was doing this, it was like really a struggle. I am showing the highlights and really edited this down. It was not this fast, but it was really difficult to get the wire to the point where we transilluminate the frontal sinus. But eventually we were able to get it and deploy the balloon in what seemed to be the right area. And so this is post-dilation. You can see we actually had achieved quite a bit. We got an opening there, and there's a potential for aeration on multiple spots. So we were pretty pleased with that. And then we did the same thing for the maxillary. And here, now, based upon where I am now, if I have a maxillary problem and it's like this, I probably would just do a standard maxillary enteroscopy. We have all the equipment in the office. I think it's easier to do in most patients and allows you better ease of confirming you don't have recirculation or some other problem. But this simply shows that we did it via balloon-only technique, sort of in the classic balloon sinuplasty, methodology that was set out back, more than 10 years ago. So this procedure was done probably about 3 years ago. I last saw him about 4 or 5 months ago. He comes back periodically for a check, and he's doing well. He's just using some fluticasone nasal spray and is quite happy with the degree of improvement that he has. This is another patient who's got recurrent nasal polyps after prior surgery. You can see that there's scarring here and here. She's had some ethmoid work. The maxillary is open on the right side. On the left side, she's got some eosinophilic debris, a couple of polyps of different maturity. So she's not chock full of polyps. The polyps are relatively mature and cystic, and she's got some scarring leading to kind of obstruction of basically sinus drainage. This is her CT scan. So a fair amount of disease and sort of a bit of a difficult anatomic configuration, but she has relatively large sinuses, so there's a lot of space in which to work. Disease is worse on the left side, and she's got this sort of partition here that's going to be an issue, and then on this side, this narrowing here. And then further back, more bulky polyp disease. Anterior ethmoid artery is relatively exposed. So clearly, we're not going to be too aggressive up in the posterior part of the frontal recess. She was a very reasonable patient. She was not enthusiastic about undergoing general anesthesia. I explained to her that, what we could achieve, and she was willing to do an office procedure with the understanding that if we couldn't get a degree of symptom improvement that we wanted, she would need a regular surgery. So this is the procedure on the left side. So she's got these bulky cystic polyps, and part of it when I start is simply to decompress them to create some room. Now we're injecting some local. Video quality here is a little bit soft because we're using not a 1080p camera, so I apologize for that. So we've got the shaver. Sometimes I'll use actually the 2.9 millimeter inferior turbinate blade shaver for nasal polyps like this because they're relatively soft and it will take them down. And because the shaver is smaller, it's easier to manipulate in the nose. It works really well for that. And so we're just debulking polyps, kind of creating some room. And so she's awake, tolerating this well. And we're able to kind of remove all of the bulky polyps that we needed to kind of open up the middle meatus. One of my concerns in a patient like this is that when you remove a wall of polyps, there'll be a thick clump of eosinophilic mucus behind it. And so you have to be ready to remove that, irrigate it out, because if you leave that behind and you don't mobilize it, it's going to cause a problem for you at some point. It's just a matter of time. We also tried to address some of the bony restrictions. So here we are opening up that compartment that was on this side, and we're kind of gently opening that up. We're confirmed where we are relative to the orbit. We did have navigation set up for this case. I'm not going to show that, but she was set up to use navigation. But the goal was to open up that subcompartment that we saw on the CT scan, at least partially, so that that area would have adequate drainage and presumably would lead to less recurrence of polyps. And then the other thing that we did for that subcompartment at the frontal sinus outflow, we elected to do a balloon sinuplasty. Now, typically you don't do a balloon sinuplasty during a polyp procedure, but we felt it was reasonable in this situation because it really was a bony restriction. And we just need to get aeration. And it seemed like an efficient way of doing that. So this is not so much for polyps, but just making sure that the frontal sinus is not stenosed. And so once we got the polyp out of the way, it was pretty easy to get the access we need to do sort of a conventional frontal sinus balloon sinuplasty, relatively atraumatic way of doing it. So I'll let this video play out. I think I show the final opening of it. So we're pulling it back, and then we're going to look. You can clearly see that we've got a much better view into the frontal sinus. It's not perfect, but again, I didn't want to take down more frontal sinus partitions posteriorly because that's going to be close to the anterior ethmoid artery, which was exposed. I mean, it's probably right here. So we had to do something that was less traumatic.